The shoulder movement can easily be assessed by three very clear movements. Arm, circular, how they are. 1, 2, and 3. These three movements completely exclude any element of shoulder restriction and can be done very quickly when you observe. You can go ahead.
Okay, with the patient's hand held out, palm down, fingers outstretched, observe the back of the hand for joint swelling or deformity, like the back of the metacarpophalangeal proximal interphalangeal joints or the wrist.
Sir,
Sir.
the extension should also be measured. Extension of the shoulder should be measured because it is very often limited on its own.
True, true, very true. This takes care of the shoulder extension. This movement requires extension and internal rotation. This is flexion and internal rotation, and this is external rotation and abduction.
Ask the patient to turn their hands over and look at the palm of the muscle bulk and visualize any abnormalities. Like we can see that if there is any hypothenor eminence wasting or there are dupuytren's contractures or something like that, if the patient has carpal tunnel syndrome. Or ask the patient to make a fist, visually assess grip, hand and wrist function and range of motion. We ask the patient to make a grip and then ask the patient to extend or flex the wrist.
There's one point I'd like to share, which I find clinically very practical. We don't have devices like ergometer and stuff like that to test the grip. So what I do is I take a blood pressure cuff, inflate it with air so that it becomes a Swiss roll. Ask the patient to hold and squeeze, and you can measure the barometric, the pressure on the mercury. Hold it for 2 seconds and you can mark it. So in periodic assessment, you can judge whether the patient has disparity of grip on the two sides, and is over time, is it improving or not.
And ask the patient to bring each finger in turn to the thumb to assess the precision pinch, neurological, if there is any neurological abnormality or something. Ask the patient to squeeze your finger to assess the strength of the patient's small muscles of the hand. Then squeeze gently across the metacarpophalangeal joint to assess further tenderness. These are some of the illustrations that we ask the patient to outstretch the fingers, make a fist, and then pincer movement. These are the movements at the wrist, the extension at the wrist, the flexion at the wrist, and we are squeezing the metacarpophalangeal joint to find the tenderness. And if we find any point of tenderness, then we can check each joint, each metacarpophalangeal joint individually as well.
Okay, if you go back one, if you remember the second picture on the left panel, we also use that for another test.
Carpal tunnel syndrome for
the carpal tunnel syndrome. This is basically for joint exam, but that can also elicit carpal tunnel compression.
We have already discussed a bit of it, that if we ask the patient to take his hands behind the head, this will assess few movements at the shoulder, and then we ask the patient to raise the hand above the shoulder, and this will tell the range of abduction of the shoulder joint. You want to add something, Dr. Kamran?
No, I'm wondering about this second picture.
This one?
Yeah, because in adults we use this maneuver to look for thoracic inlet obstruction, outlet obstruction, because it causes congestion and suffusion of the head. In the children it may not be so relevant, but if there is a fusion of the cervical spine, then this will be significantly limited.
Look for rotator cuff syndrome,
rotator cuff syndrome, yes.
If we are talking about movements at the shoulder, about the rotator cuff or
right. There was one slide previously which.
These are some TMOs from our